Labrum, if there's a click, that's involved as well. And also that's an indication of previous or history of dislocation. This is at stages. So this is just passive external rotation. And you're looking for apprehension. Okay? So the ones we are going to practice. This is the one. So again, make a note of the ones we're going to practice. This one. Relocation test. We talked about what position the head of the humerus goes in, or which way it moves when we put somebody into abduction external rotation. The head of the humerus tends to, and you can do this on yourself, just go into external rotation like this. The head of the humerus has a tendency to move anteriorly. So the relocation test, you apply, you put them into the position of apprehension, and you only do this if they are apprehensive. Okay, so you don't do this if they have no symptoms. So you only do this with a positive apprehension test. If they are positive, you apply an anterior to posterior force to the humeral head, and the pain should go away. If the pain goes away, or the apprehension or the symptoms go away, then that means that the apprehension suggests, along with this, that the problem is the fact that the anterior head of the humerus, the head of the humerus is going anteriorly too much. Okay, so how do you fix that? You can either work on strengthening for the stabilizers, or they have to shrink the anterior part of the capsule, so surgically. Okay. So decrease pain and or increase range of motion. If you relocate and they are able to go further without symptoms, that's also positive. Anterior, increased laxity in the capsule. Or posterior, some people might complain of pinching in the back part of their shoulder. So there's potential and impingement back there as well. The posterior capsule against the glenoid rim. And again, if there's pain posteriorly, it could be a problem with the labrum. Okay. So those are some of the things that you'll find or potentially find with a positive apprehension and relocation test. The surprise test is you just let go. So you apply the anterior posterior pressure to relocate. When you let go, if the symptoms come back, so that's the face I was talking about, then that's, again, that just confirms that there's anterior instability. Looking for pain or clicking also indicates labral pathology. Okay, so apprehension, relocation, and surprise go together. So we'll practice that one. The anterior drawer test, we practiced this with joint mobilizations or joint play movements. So with this, you have to stabilize coracoid process, the spine of the scapula with the one hand. In this picture, they're actually grabbing onto the surgical neck of the humerus. Okay. There's another test called the load and shift where you actually move your hand and grab the head of the humerus. Okay, so with the drawer test, traditionally, you're grabbing the surgical neck of the humerus, hold down the scapula against the table, and you're pulling the surgical neck of the humerus along with the head anteriorly. How much it translates compared to the opposite side will tell you how much instability there potentially is. Okay, so laxity. And again, if the person reports hearing a click, there potentially is labral pathology as well. Okay, so that's your anterior drawer test. The load and shift, typically they're sitting. Okay, if you want to do it in supine, you can do it in supine as well. With the load and shift, centering the humeral head in the fossa, so what they're actually doing is compressing the joint. They're taking the humeral head and pushing it into the glenoid fossa, and then shifting it. What that does is it loosens the joint capsule a little bit, and so you should be able to move normally the humeral head anteriorly and posteriorly, a little bit further than normal. Okay. Again, by pushing the humeral head into the joint, you're loosening the joint capsule. So you center it into the fossa. Once centered, that is your baseline. From that centering, draw it forward to see how much translation there is, and push it back to see how much posterior translation there is. And that's the shift. So the load is pushing it into the glenoid fossa. The shift is the translation that you apply. Now, a positive is the degree of laxity. These are some of the numbers that they actually have in the book. So if it translates 25 to 50% of the width of the humeral head, then that is a lax glenohumeral joint. So this is based on the size of the humerus. Okay? So it's kind of a ballpark. So here's an example. So that's your glenoid fossa, that's your humeral head. So if it translates this much, that's normal. 25 to 50%. So here to here is normal. If you keep pulling from 50 or more, that's lax. There is normal translation. Okay? So let's say it sits like this normally. When you center, when you do the load, it should be centered like this. Okay? When you shift, you translate it anteriorly or posteriorly. If you translate anteriorly less than 50%, so in here, that's normal. If it goes more, then that's lax. If it comes out, you'll hear a clump. Okay? So that's what those numbers represent. Okay? Any questions about those instability tests? Okay. So let's do those ones quickly, and then we'll get into the labral stuff, and then posterior and inferior instability as well. Okay? So with this, anterior drawer, apprehension, relocation and surprise, and load and shift. Okay? 5 minutes.